and I think we'll go ahead and start. Welcome to today's webinar, Diabetes Effectively Utilizing a Certified Diabetic Educator. Just a couple notes before we begin. To obtain nursing contact hours, you must have entered your license number at registration. You must be logged in individually with a unique email address to the webinar for the full duration of the presentation. No partial credit is available for this webinar. A nursing contact hour certificate will be emailed to you after the presentation. A certificate of attendance after the webinar, you will receive an email link to the evaluation. For all disciplines except nurses, a certificate of attendance can be printed after completing this evaluation. And now let me introduce today's speaker. Karen Roos, RD, LD, CDE, graduated from Iowa State University in dietetics and became a registered dietitian in 2008. In 2011, she obtained Certified Diabetes Educator status. She currently works as a program director and RD, CDE for an ADA Certified Diabetes Center for Mercy Clinics in Des Moines. She provides a variety of services, including diabetes self-management training, personal nutrition counseling, group classes, and support meetings, and also assists with continuous glucose monitor and insulin pump management. Welcome, Karen, and go ahead and get us started.
All righty. Well, hello, everyone. Thanks for joining me today. Again, my name is Karen. I'm the registered dietitian and also CDE for an internal medicine clinic here in Des Moines, Iowa. I am the program coordinator as well as the primary educator for our accredited American Diabetes Association Diabetes Center. And we actually have 5 providers in our clinic. One is also a CDE, but doesn't really practice, much in that practice. Of course, having an education program in place for us is all about, improved patient outcomes, but also is so important for an organization when it comes to being able to charge for those education services. So we also hold the certification to be a PCMH clinic or patient-centered medical home, as we can provide the patient with many services in-house without, the patient needing to make several appointments. And I do think diabetes education is becoming more and more common in the clinic setting rather than a specialty clinic or endocrinology. So today I'm just going to share with you really how the CDE is so important in the team approach for diabetes care. And we'll just run through an example of our clinic flow that has really worked for our team, but of course can be adapted to many clinics, many scenarios. And also how the CDE can be that glue, between the patient and the primary care team, and just as well as that go-to diabetes education resource. And we'll also just touch on, those important education topics touched on in our patient visits, whether your practice has a CDE or no CDE. So, diabetes education. So of course can be done in individual or group settings. I think individual education is becoming really more and more popular. We do need that specific referral of why that patient might need individual education versus group education. Individual education could be needed for situations such as, of course, trouble hearing or seeing if the patient is on an intensive insulin regimen or insulin pump, and so on. So these forms for referrals can actually be created or put in your specific electronic health records referral process. And these referrals, include specific instruction detailing what should be covered specifically, as well as the hours of education needed, based on what the provider feels would be necessary. So we really do a lot of linked appointments in our clinic. So with the educator and provider, meaning they will see the educator and provider the same day. And it just appears just very beneficial for the patient, and that patient feels really a big part of our team. Of course, if needed, a referral to endocrinology or a separate education clinic can be done, but really isn't necessary if you have someone in the clinic that is designated for that role. So, that so-called diabetes champion. So this would be that individual that would, just keep up on current information regarding diabetes and be that one go-to staff member. And this could be anyone in the clinic passionate, such as a provider, a CMA, RN, health coach, care coordinator, that's just really already built into your staff. So, again, this person would just need to be informed and have those education resources on the main topics of diabetes self-management training. So of course, our diabetes, education curriculum is based off of the American Association of Diabetes Educators, or AADE 7 self-care behaviors, which I'm sure many of you are familiar with. This can be done throughout several appointments and really is based on what that patient is needing to work on most. So of course, those being healthy eating, just creating those realistic eating goals and knowing that nothing is totally off limits. Being active, just, starting with getting moving, more with day-to-day activities, monitoring or checking blood sugars, or would that patient, benefit from having a personal CGM device, which we'll touch on a bit later. Taking meds correctly and medication adherence, I think that's a huge role of the CDE in this team approach. Problem solving, reducing risks, and of course, healthy coping. So again, all of these should be covered and touched on at some point. But again, we really should focus on, what's relevant first for that patient. So our first step is, we begin with an initial assessment from the patient. Typically, this is a form the patient will fill out prior to the appointment about their knowledge of diabetes, their history, hospitalizations, any financial issues that could be a barrier, depression, and how, also how that patient learns best. Some clinics will actually mail this form prior to the appointment or hand out in the waiting room. But I prefer to really review this personally with the patient and just sit down and actually do this with the patient in the clinic. We then would rate that patient's initial knowledge on a 1 through 3 knowledge scale. So for each topic, and this would be documented at each visit in the chart, just to be able to review and know what to continue to discuss. And so our scale is just a very simple 1, 2, 3. So 1 just meaning needing instruction. This patient may be very new to the topic or just really is struggling in this area. 2, needs review and assistance, meaning yes, they've grasped it, but there just is that need for continued education and reinforcement. And I definitely think a great example of this is carb counting. Is just from my experience, this is something that never really, we can't master 100%. So, and 3 demonstrates competency. So these are usually those technical things such as monitoring or, glucometer use. So I generally just start with that open question of, what do you currently understand about diabetes, or what would you like to learn? So, and I do find using those visuals and really helping the patient understand what diabetes is a great starting place to get them involved in their self-care. So let's just do a little breakdown of those 7 self-care behaviors. And again, I'm just going, mixing up the order in which I discuss these based on that specific patient. So we'll just start with assessing monitoring. So where have their blood sugars been, and what is that most recent A1C level? So I think some big discussion should be, does that patient have a working glucometer with affordable test strips? Would a copay card help with savings? And generally these savings cards can be even downloaded on those glucometer, the brand's websites, or even comes with a sample glucometer. We are lucky enough to have reps bring those into our clinics just to have on hand for training. Generally, these cards do not help with Medicare patients, and this can be frustrating. But I think recently I've really even pushed patients to go to even just a cheaper brand of meter, such as the Rely On brand meter. And this can be purchased at Walmart. It's just basically a $9 machine, and you can actually get 50 test strips for around $9. So, affording test strips, if that's an issue and there's a $50 copay, meaning that's why the patient isn't checking blood sugars, this can be a great resource. And also, does that patient know how to use the device and appropriately check? So I think it's important to watch them do a blood sugar check in the clinic and just discuss those alternate testing sites rather than finger sticks. And again, we know those testing sites, may have an accuracy issue. But if someone is just unwilling to do a finger stick, we're better off with just getting that blood sugar rather than not. And again, so many of our personal CGM devices now are requiring little finger sticks, and actually some of the newer ones are moving towards needing no finger stick calibration with many benefits such as high and low glucose alerts. And then just that tracking, being able to track those blood sugars. So luckily in our office, we have a few different programs where that patient can bring in that meter, we plug it right into the computer and actually can pull off all of those blood sugars. So that's just an easy resource in the clinic. And also, do they have a logbook to even track those blood sugars? So again, we can get those from, any of the pharmaceutical company websites, and those are generally just free to order. But I have found most patients, especially our younger patients, really don't want to have to carry and track those logbooks, anymore. So really, I think, finding these monitoring apps, would they be interested in downloading an app on their phone, to really track those blood sugars, keep a diet diary, and even track activity. So these are actually just a handful of apps that do have a free version to download. They do have upgraded features, but tend to cost extra. So just the basic version I find is okay. And really it is so handy when it comes, when the patient comes prepared with that data or their logs, they can actually upload at home, create those logs, on their phone, send me an email, and I can actually print off their reports prior to that appointment. Of course, if the patient is on an insulin pump or even a personal CGM device, these can actually be downloaded from home and linked to a professional account, so that we can just pull that up when they arrive. And again, this is just all free as long as you can set that account up online. So, in just really knowing what those blood glucose levels are, where should they be and at what level do they feel that high or low, and how to handle those situations. So I always quiz patients on, do they have those blood glucose tablets handy at all times, in their bag, in their glove box, and also to, offer suggestions for other treatments of lows. Something as simple as 3 sugar packs can work in a pinch. So treating, for 15 to 20 grams of carbohydrate for their target low blood sugar, and just reviewing that often, I think is so important. And of course, on the other hand, which I'm sure many of you see, would be over-treating those low blood sugars. So again, helping the patient to self-manage and come up with a low blood sugar plan to avoid the high and low, that roller coaster effect, can be so helpful. Of course, when communicating, when to communicate those blood sugars to the provider. So what is that critical, number? What is that protocol in your clinic? So, and again, I'm sure this varies from patient to patient. I think we know now that really most of these recommendations are moving towards that personal goal of not always having that A1C of less than 7%, or, our 85-year-old patients at home on insulin, we're not shooting for that target blood sugar of 100. So just really creating that personal goal with that patient. And of course, sharp safety. Is the patient disposing of lancets and needles safely and what can be used? I often recommend a hard plastic container, just such as an empty detergent bottle that's labeled and kept away from others. So that's just a quick, easy, cheap solution. And of course, medications. And I think this is a huge part of the CDE role in our clinic, and I think in any clinic. So I generally have the patient bring their medications in the original pill bottles to their to their appointments along with their insulin. And we do print an updated medication list, linked to the diagnosis at the end of each visit. So I think this, again, is so important with that medication adherence. And also, really discuss why they're taking those medications. What does that specific medication do in their body? I often find a patient will say, well, the doc started me on this medication, so I went ahead and stopped the other one. Well, we really needed actually both of those because they work so differently in the body. So just helping them understand why they're taking these medications. And I really think the biggest issue is affordability. Diabetes is expensive. So unless you're talking about basic orals or older insulins, newer therapies like GLP-1s, some of our newer insulins, they really add up. And of course, there can be some point where, yes, this medication is beneficial, but simply is just not going to work when it comes to cost. So I think it's so important to check, insurance coverage, offer the patient assistant programs when available. And these are just easily printed out forms. I print several of these a day. And the patient just needs to fill out their information, bring in some specific documentation regarding their income, and oftentimes they can even get, very discounted to even free insulin shipped to the clinic. Also, even copay cards, considering generics, and, if you're lucky enough to still get samples in a clinic, that's a great resource. And sometimes, for example, I know BD, often we can even, order free samples online. So pen needles, insulin syringes, injectable starter kits, and also, a variety of free information can just be ordered monthly. And again, another issue with medication adherence, I think, again, is this proper training. Of course, drug companies offer free training videos and education on their products, tear pads, mini videos, and I know YouTube really has a great variety of videos on proper injection trainings and techniques. And just one specific patient comes to mind in this situation. He was actually establishing care in our clinic and was insulin requiring. We just could not understand why his blood sugars were so high after every visit, increasing his insulin doses. And of course, we needed to work on some dietary intervention, but something just wasn't adding up. So we finally had asked his wife to come to this, his next office visit and be a part of our team, and asked him to demonstrate how he would do an injection in the office that day. And his wife just kept mentioning, I think he needs longer pen needles and the insulin leaks out. So we actually came to find something as simple as he wasn't even removing the pen cap off of the pen needle. So something is just as simple as that can just be, completely life-changing. So had the patient really been taking that insulin correctly, that could have really ended up in a dangerous situation. So again, also things like proper storage, are they storing their meds correctly? Not keeping that insulin cold and refrigerated and using it for months can definitely be an issue. And also the opposite, knowing that insulin is stable at room temp when opened, so they can carry, when dining out or traveling. So just to know those extra tips. So I think just discussing storage, expiration date, travel safety, these are a lot of these things that, we hear from our hospital colleagues, that a lot of these patients will go in and they've been using insulin from 6 months, 6 months ago that was actually expired. So just kind of these little touch points of information I think are so helpful. And again, so many of these, tear pads and instructions can be ordered from many of these insulin company websites. So just great handouts regarding sick day, instruction, and so on. And of course, being a dietitian is a big topic of nutrition. So I generally have the patient, before they come in, especially a new patient, keep a 3-day food journal, to bring to that appointment and review. And I think 3 days seems to work well. I'll say, go ahead and pick 2 work days or, 2 weekdays and a weekend. And I think anything more than that, I kind of tend to get nothing. And we also have them write, as one of our doctors calls it, the yummy evil foods, or, just foods they can't live without, so that we can really discuss ideas how to work them into their meal plan or modify them a bit just to be healthier. So questions may be, does the patient, are they able to cook at home? Are there any local grocery stores that offer cooking classes, or even local extension offices can offer these services? Do they dine out, and how often? And what kind of restaurants, are they going to? So offering those dining out tips, such as, something as simple as serving fries with a side salad or taking off half the bun to cut down those carbs, can really be helpful for patients. And also, I think really discuss, how those certain nutrients affect blood sugars, and just, of course, counting carbs. I think counting carbs comes kind of with this bad stigma, but I try to make it breezy and just focus on simplicity. I use the carb counting meal planning book from Novo Medlink. I love this book. I don't know how I'd make it through each day without it. It's a free resource, and you can order a max amount every month through this novomedlink.com. Just set up a free account, and you can just order, I think the max is about 10 per month at this point, but you can also get from your local rep. Our clinic also utilizes the American Dietetic Association Nutrition Care Manual. This is just a yearly online subscription that provides dietary information and really has excellent printouts and printable handouts for multiple dietary recommendations, not just diabetes. And I probably, again, use this daily kind of in my initial education packets. And of course, our providers also use UpToDate to print out those specific education materials, whether it's, diabetes to the DASH diet. So many different options. So again, there are many angles you can use to teach those healthier habits. And my big motto is, to patients that no is not an option. So many come to me and say, well, I was told I'll never be able to eat this food again. And I just want them to know that we can fit these foods in and they just need to be reasonable. So when appropriate, teach that carb counting and label reading. And again, if they're on multiple daily injections or insulin pumps, I feel it's pretty necessary they should have a good grasp on that carb counting. But sometimes carb counting is just not something the patient is willing to do or understands. So just try simplifying by using portion plates or visual food models. I also have a handful of portion plates that I've ordered online for free, again, through this NovoMed link, and to give to patients that, it's just, they also have some excellent free handouts with visuals of this plate method, and also even tear pads on the effects of alcohol and relevance of blood sugar. So these are actually just a handful of diabetes-related websites and apps that I've found that are just very useful for patients. I use the calorieking.com daily. In fact, it's generally up on the tab on my computer. So when discussing, carb contents of foods, I just turn my computer screen and the patient and I will look up items, review nutrition content. I think it can be very eye-opening. It's just a huge database with restaurants, a variety of foods, and other food database, apps that I find are favorites are GoMeal. It's GoMeals, which is also just the app of Calorie King. And I'm sure many of you have heard of MyFitnessPal. This is great for tracking intake and setting goals, as well as offers a great food database. And of course, dlife.com. It's a huge website full of great general information, but I really love their recipe database from appetizers to desserts that just really include that portion control and nutrition information per serving. So, of course, assessing moving, just getting moving, asking what that patient does daily for activity, and keeping in mind those barriers of, possible neuropathy, or do they use a walker? So just encourage activity as tolerated if cleared by the provider. So are there local gyms available, school gyms with open gym nights, pools, or just simply walking? And I have many patients that actually just take advantage of those big box stores, just walking laps, and really trying to count those steps. And one of our docs really recommends the Garmin Vivo Fit. It's actually a cheaper version than Fitbit, and it's just a very simple device to use. It's just a very easy step tracker. But again, many of our cell phones even have those step and activity trackers already on them. So just any idea to get up and get moving. But the main idea is to find out, what's enjoyable to that patient and how to incorporate that in their daily routine. And of course, if the patient is on a sulfonylurea or insulin, being able to discuss exercise and hypoglycemia risk. So the next would be reducing risks, just a discussion about complications, both acute and chronic. And again, this can be done through multiple appointments, but covering all topics is important. And I think the first important, it's to discuss causes, symptoms, treatments of both hyper and hypoglycemia, and when to seek medical advice, as well as sick day management and what to expect with illness. Also, if on a medication that would cause hypoglycemia, safe driving, and low blood sugar. And again, I tend to use many different free tear pads from these insulin companies. They have great options where even you can build your own tear pads for your own clinic that have those specific topics on it. And of course, topics of chronic complication, such as neuropathy and foot care. We do foot care and examinations in our clinic and do track these in the patient charts. So demonstrating to the patient how to properly examine their feet and again, discuss, signs and symptoms of foot problems and proper foot care. We are lucky actually enough to have a podiatrist on our Diabetes Center Advisory Committee, so we do have a good established relationship with that clinic. Retinopathy, again, reviewing the chart to see if that patient has had a dilated eye exam in the past 12 months or more if warranted. And again, we're lucky enough to have that retina specialist on our advisory committee, so we do have a good resource. Nephropathy, of course, following lab values as well as annual microalbumin screens to help facilitate medication changes needed or even possibly a referral to nephrology. Cardiovascular disease, and just helping that patient to see that link between diabetes and cardiovascular disease. I think we're fortunate enough now to have several of our diabetes medications that actually reduce the risk of cardiovascular death in adults with type 2 diabetes and heart disease. And of course, sexual dysfunction. This can be a difficult discussion for patients and can be a big issue in their personal life. But if warranted, the patient or the provider can actually have this discussion. And again, I think copay cards, really come in handy because these medications can be very pricey. And of course, dental care, stressing that importance of dental care and encouraging those visits with their dentist every 6 months to a year as needed. So, making sustainable lifestyle changes, mental wellness, and coping with chronic disease and the benefits of reducing risks. So these topics can run together a bit. So with diabetes self-management, our goal is to give that patient the tool to walk out of our doors and manage their diabetes in their daily life, without our help. So helping the patient identify what lifestyle changes they would feel would be beneficial and what behaviors would need to be changed to achieve this. And then discuss strategies with them to achieve those changes and goals. And I know, we recently have been really making sure that that patient leaves with a goal sheet in hand with at least one goal that they feel is achievable between now and that next office visit. And again, being sure that those goals are SMART goals so that they're specific, measurable, attainable, realistic, and timely. I think sometimes it's very easy to tell the patient, well, you need to lose weight and eat healthy. And I don't think that this is news to most people, but helping them come up with a strategy and plan that really puts that in place is what's beneficial. So again, creating that goal contract or just something that they have written down as a solid goal and a reminder to work on until next visit. So really healthy coping and support to help them be successful when they walk out of our office door. So what does the patient currently have outside of these four walls? Friends or family? Do they attend church or any community activities? Would counseling benefit them? So I often discuss with patients that even though their life may be full of, complications and problems that they can't control and maybe struggling with depression, that diabetes can be that one thing that they can be proud of at the end of the day, that they can control this. And again, these are all examples of outside support that the patient can utilize to be successful with their self-management on a day-to-day basis. And then again, we do create a printable list of all of these resources for the patient. So the patient should leave each appointment with a goal, a plan to achieve this goal, and then a plan for follow-up to come back to the clinic to continue to move forward with those future goals. So finally, the team approach. So all of this education really works best, and will provide the patient with the best outcomes when utilizing that team approach for diabetes management. I really like to describe our clinic as sort of a healthcare one-stop shop. Again, we are that PCMH clinic. We do have that ADA certified program so that within an internal medicine clinic so that really that patient can, be cared for in many different areas. So who is on our team? So who's on your team, obviously will vary greatly, but most likely most of you will have this as a backbone. Of course, the patient is number one. This is who we are working for. Our front office staff, scheduling patients and doing those oh so important reminder calls for upcoming appointments. And our office staff actually, front office staff will remind that patient, please bring your glucometer to your visit or anything, those little side notes that we ask them to do. Nursing and lab staff also does glucometer and CGM downloads. They do point of care A1C in the clinic as well. And they also have access to all of our diabetes information that the patient may request. So many clinics also have that health coach or care coordinator. Ours works a lot with, patient follow-up post-hospital, but also assists in medication adherence, training on injectables, and also some glucometer training. And they're just so helpful in our situation with, these follow-ups and all of these extra phone calls that we need to make. We also have a Medicare annual wellness nurse in our clinic at least 2 to 3 days a week. And she actually does a lot of our chart review for our Medicare patients, just making sure they're up to date and, passes this information on to the provider. And we actually are lucky, we're blessed to have a licensed clinical social worker in the clinic, and she actually does specialize in EMDR, so can help with a lot of those eating and nutrition issues that patients struggle with. And we will often coordinate those visits with her, myself, and the provider all in the same day, which I think really seems to improve that close follow-up. The CD and the provider, of course, and then any outside pharma or vendor support. So, for example, we do utilize clinical staff from some of our insulin pump companies for our pump trainings. They are scheduled to come in on specific days in our clinic, and we'll also do follow-ups with the patient to ensure they're doing well, and will work with us and make suggestions on possible, settings and adjustments. And it's just been really healthy as these appointments are very lengthy. So it just helps us with just that extra time in the day. So our clinic flow, so really over the years, and we continue to learn what works best, for clinic flow, but generally the PCP will place a referral, which is required again for CDE education. And again, we have those forms built into our EHR. The front office staff will schedule those appointments for the patient. And generally, these are linked appointments. So typically not always, but the provider will generally see the patient after me. And what's really helpful is we all sit together in the same office and, we review blood sugars and come up with a plan as a team. And of course, financially speaking, the CDE can bill an education visit and the provider can bill whatever level is appropriate for that office visit that day. So it really works well for our patients as they're able to focus on their diabetes and spend a lot more time with me, then discuss, any other issues with the provider, such as, possibly being sick, blood pressure issues, they're just not feeling well, so that they don't have to have a separate visit, which works quite well. So if the patient happens to have a diagnosis, or an A1C that warrants education that day in the clinic, they are scheduled with myself, but we also will train on a glucometer that day that they're in the clinic. And this can be done by anyone. So all of our staff is actually trained to be able to train on these devices. And we also have a general packet of just general information to hand the patient just to get started. And even if, if something as simple as metformin is started at diagnosis, we do write out the instructions, how to titrate the dosage, and our policy is always to send that medication to their pharmacy before they leave the clinic. And I really think that helps with medication adherence. Myself or our health coach have basic packets of educational material to send with that patient. And again, those providers and nurses can just hand the patient that day. If needed, or more intensive meds were added at that appointment, myself or our health coach will make, follow-up phone calls just to be sure that patient is doing well until their next visit. So these linked appointments. So I've been lucky enough to be a part of this model since I started this years ago. A doctor in our private practice was already doing this, and it was a bit unorthodox at the time. But I think the linked appointment model has been such a great tool for, the patient, the provider, and it really improves outcomes and trust. And the patient is, they're always scheduled with me first, then actually will, be seeing the provider a bit later. But I generally will grab the patient from the waiting room, gather vitals, start the office note, review medications, and do a quick chart review. Just updating health maintenance checks such as eye exam, mammogram, colonoscopy, podiatry visits, etc. I will also always check to see if the patient needs an A1C, and we'll get that started right away. So our point of care A1C machines run in about 6 minutes. So our patients have kind of come to expect, and they almost wait in anticipation for that result, almost like it's a challenge. So And of course, then based on that result, their glucometer downloads, their pump or CGM upload, or any pertinent issues that day, I can actually tailor that education topic to what is relevant. And then I will, of course, grab that provider and we do a quick review and I make some suggestions to therapy we discuss before we actually talk with the patient. And then we all sit down together and come up with a plan. So oftentimes, again, I'll just turn my computer screen and have that CGM upload or, pump upload, and then really explain, this is why we're making this carb ratio change or this correction factor change. And again, our providers generally will do the exam and address any other issues, the patient may be having that day. So we also do lab and x-ray right in clinic. Then of course, the patient will be set up for that follow-up. And I just find that, patients, especially new patients, just tend to really gain your trust as a CDE when the provider comes and joins you. They really feel a part of that decision-making process. So far I have reviewed the role of the CDE in the clinic as far as patient care, but obviously there are many other things we do during the day. So working, with other staff such as health coaches or care coordinators on continuous quality improvement projects to better, overall patient care. Generally the hospital inpatient education staff has a great connection with us and, we're able to really help patients make that appointment or have that follow-up appointment post-hospital. And, of course, any follow-up questions, after the patient has seen the provider, it's just easy to kind of get a hold of me so that I can run through any of those quick questions and answers. We also hold staff in services just to be sure all staff is up to date on new medications and monitoring devices. And we do have clinic huddles each morning, and these, again, can be great education touch points, as most of our staff attends. And like I'd mentioned regarding those linked appointments, that shared group decision making, I think that's, again, a huge part of the CDE role. Education with medication and follow-up, improves that medication adherence, which I'll touch a bit more on shortly. And, I think this is becoming a big goal in many facilities is that medication adherence. And again, I think that the CDE is generally in the loop for all of the community diabetes programs or events and can facilitate involvement of patients and staff, including walks, bike rides, and really, I think overall it's time. A lot of our doctors will say, diabetes isn't, it's not rocket science. It's just, it takes that extra time with the patient. So diabetes education just takes that substantial amount of that office visit time. So it's so helpful to have the CDE or anyone in the clinic that can spend that extra time. So just a few recent facts regarding patient medication adherence. And again, this is why that CDE is so important. So only 50% of prescriptions dispensed are taken correctly, thus the importance of teaching while that patient is in the clinic. And again, I recently saw a patient on a GLP-1 agonist that was prescribed by her PCP, sent to the pharmacy, no training, and which of course is an injectable pen. And when I asked that patient to do the injection in the clinic, she was actually just putting it in her skin, not pushing the button, and actually not even receiving any of that medication. So just another reason for just close follow-up and actually training in the clinic. Another reason for follow-up calls and touch points, only 31% of patients, they never fill that first prescription. And just over 1/3 of patients stop taking those medications earlier than instructed. So it really takes a team to manage chronic diseases like diabetes that require the patient to maintain these intensive therapies. And of course, there are the ups and downs, but with close follow-up, from my experience, this improves that medication adherence. So, of course, insulin pump and continuous glucose monitors, these can be a great tool for patients, so hopefully it improves outcomes and really helps to simplify diabetes for a patient. So we use a variety of insulin pumps and CGM devices in our clinic. The CDE can actually help identify what patient may benefit and also help to figure out, who would qualify for insurance coverage, and also help that provider be sure that they are including the proper documentation in the notes to support that coverage by insurance. Of course, this is again when vendor support is so helpful, as they do bring me in plenty of pamphlets and demo devices that I can actually offer the patients to review before making that decision. And also that starting the products and training. just having that extra help, because it does take so much time and is, it's such a workload, that we utilize that clinical staff from those companies. We generally have the patient and trainer meet in our clinic so that we're certain to have all of our recommendations that are being followed. And if there's any questions arise, we can all work together as a team. If possible, we have the patient set up an account online and really have them do a lot of uploads at home so that we can review consistently. And these actually can be interpreted, these uploads, by the provider and is billable every 30 days for most insurances. And again, just, time is a big issue. So it takes time to upload and simply just pick through these reports. So again, another role of that CDE. So aside from the patient having personal devices, there's a great benefit to having professional CGM in the clinic, and this does not necessarily require a CDE to be on staff, just anyone that can be the go-to person for this. So if professional CGM is warranted, generally the provider will just, schedule with me to start the training. And, again, even if I have time, I can do this quickly and just start it that day that they're there. And of course, you have to consider the patient, will they be able to work that technology? So we have both blinded and non-blinded CGM. So it just really depends on what works for that patient. We do send a food, glucose, medication diary with the patient so that they'll return for download. And the CDE can actually bill for the CGM start, and the provider can bill for that professional download. So again, when we do these linked appointments, we all review these results together. And I think this can really be eye-opening for patients and can be a great tool for providers to really make adjustments. So I've gone through, of course, the benefits of having a CDE in the clinic. And of course, what if there is no CDE available? I think the daily role of a CDE can be mimicked by someone who is passionate about diabetes and is just willing to spend this extra time to possibly provide some of these services. So assessing the cost, and or benefit of having a so-called diabetes champion in the clinic is very important. And then, tailoring that person's services to, really what are the main needs to the clinic for those patients and providers. And also, if possible, utilizing telehealth or Skype. I know that some of our clinical insulin pump staff utilizes this for some of our rural areas. Many companies, offer educational videos that are credible, and, having these available in your clinic as almost like a training library can be very beneficial. And honestly, just free material from pharmaceutical companies, they have great teaching tools. So many of my patient education packets come from these. Our clinics really don't even have to purchase much as far as education materials. And they offer great carb counting material, tear pads on pretty much every topic that's required for diabetes training. And again, having that professional CGM in the clinic and really who is willing to place and download these. So again, it's really important to network in your community, to work as a team. Of course, partnering with other local clinics for resources as well as pharmacies. Focus on what your specific outcomes and celebrate these successes, and really see the goal of what is trying to be accomplished. So maybe even what are your survival skills? What do you need day to day to improve diabetes outcomes? And just really focus on this first. Of course, assessing your flow, space, which, just to prove how little space is needed, my office is an old procedure room. It has a large closet for diabetes material and our pump and CGM devices, and we have one download station for our nurses. I have a cheat sheet at those stations for each nurse to really just be able to kind of download each device. And again, just utilizing those free resources from pharma education. So the goal is just really working together to create something that is workable and beneficial for the patients, the providers, and staff. There will always be change, so being able to bend and adjust to those changes is crucial, and showing the value of diabetes education for patient outcomes, of course, but for the facility as well. And of course, building a great team and, really leaning on each other for help, having everyone on board and have that basic diabetes education survival skill, and you'll have a great start. So that's what I have today, everyone. So if there's any questions, I'd be happy to take those at this time.
Thank you very much, Karen. If you have a question, just remember to unmute your line. And if you're not comfortable speaking into the phone to ask a question, you can always type your question into the chat box and I can ask Karen. Karen, can you tell us a little bit about how long the initial appointment takes when you have that linked appointment, and then maybe subsequent appointments, how long each of those take?
Sure, absolutely. So generally, a new patient visit for myself for individual visits is 1 hour. And then, of course, the doctor generally spends an extra 20 minutes. So their appointment would be 20 minutes with the doc post. So it would take about an hour and a half total that the patient would be here. Post visits are generally on my schedule. I have 40-minute appointments for just general, education follow-up. CGM starts are generally 1 hour, and insulin pump starts, if I do have time in my schedule, are generally blocked for about 2 to 3 hours. So. And of course, we do utilize the education code is that G0108, and that is done in units. Of course, each insurance company gives the patient so many units per year to utilize, and generally Medicare provides 10 hours of diabetes education that first year, 3 hours of medical nutrition therapy, and then generally it's 4 hours thereafter each year, so they can continue to come back in. So I do think it's important that the patient, continues to come in for education. There's always something new, and I know our docs do each year just kind of review to see if the patient has been in for diabetes education within the last 12 months.
And among the sources you listed, do most of them have non-English speaking pamphlets or such, or resources for immigrant populations?
Absolutely, especially the printable handouts. Many of your insulin pump company sites that offer any of this information, does come in Spanish, and obviously we can request others as well. But I do have definitely a great supply of those just to keep on hand. Luckily, we do have those resources within the clinics, and obviously Mercy being quite large, we have interpreter services. So I do create packets for, Spanish speaking patients as well.
Okay. And can you tell us a little bit about the goal setting process? Are you setting the goal in conjunction with the patient, and how do you prioritize what the goals are? How many goals are you setting with them at a time?
I really think that it's individualized for the patient. We at least set one goal per appointment. Many patients can say, Karen, I think I can do this, this, and this. So maybe even 3 goals, but we try to keep that realistic, between each visit. And it's so important as far as, having that goal contract with the patient, really sending them out the door with something in hand that says, okay, this is what I'm going to work on over the next, month, 6 weeks. And I do think it's also important just to remember that I think many of us think of our diabetes patients coming in once every 3 months. We see them for an A1C, we'll give them a couple goals, we'll see in 3 months. Our clinic is a little more aggressive. We tend to say, okay, you're really struggling. That A1C is up to 9.2. We're going to see you month to month until that next, A1C. So we can really break those goals down month to month to make it a little more doable for the patient.
Question from our audience. Are you typically billing 1 unit then for post visits, or is it like one code for multiple visits?
So generally, of course, I'll bill the 2 units for the hour for the first visit. Generally, I try to keep it within 1 unit just to try to stretch, that time out, because we know we only get so many visits per year. So I do try to keep it, and really, really focus again. I think that's what's important is focusing on what's important so that you can get through that topic at that visit to really maximize, the education for the time that we're given. So yes, I tend to bill 1 unit. Of course, if it is a really lengthy visit, it may warrant 2 units, but I try to keep it at that one for follow-ups.
Another question from our audience. Do you find your patients are pretty receptive to being billed for education at each linked appointment?
Our patients, I think, have really come to see that benefit. Really, if you look at it versus going to an endocrinology, office, usually those copays are higher for specialty visits. But generally, our patients, I think they feel that benefit. They really feel, and I think they see the impact in their health. That it is so beneficial. And really, for most patients, it's a time saver. It's kind of, again, it's that one-stop shop. I'm coming in, I will see Karen that day. We'll really kind of hammer out what I need to as far as my diabetic issues. We'll get my insulin pump uploaded. And then, of course, if there's a cut on the foot or, an infection, the doc is going to be in. We're going to hammer out those diabetes issues, and then let's go ahead and discuss anything else further. So I feel like it's really all-inclusive. I don't feel like that's been a huge issue for a lot of our patients.
Okay. Another question here. Let's see if I can read here. For Medicare patients that do not have reason for a one-to-one visit, you then see them 1 hour initial and then have them attend group education.
We do offer group education. We have fairly limited group education in our clinic. We just generally haven't had a lot of luck with that. We offer group education every month. It's just something that hasn't been very successful. I would say the majority of my patients are more they need more intense education. They need that extra therapy. Most of my patients probably are on injectables and pretty intensive insulin regimens. But yes, I think for those patients that are newly diagnosed that I can kind of fit into a group, I try to see at an initial visit, and then yes, we can follow up with that group visit as well. So.
And how many patients are you typically seeing in a day, and then are you seeing patients 5 days a week?
I see patients 5 days a week. Generally, I'm up to about 9 a day right now. It's pretty busy. I think we definitely are growing in just our internal medicine office. I think that patients find that it's easier for them. They feel a little more at home here, but yes, it's definitely very busy. But I also do a lot of things. I think that the docs really, I've gained their trust, and we've really gained a relationship that, I can certainly send in a medication if we need to. I can do those vitals. I do a lot of things throughout the day other than just see that patient to really just, help out in the clinic. So it really gains that trust. And I think that being in the four walls with your doctors, you will really see that trust, and they're sending you patients every day. So my schedule is pretty full.
And how many providers do you have in your office currently?
We have 5 providers. We have one nurse practitioner, 1 PA, and 3 DOs.
Okay. And can outside providers refer to your services without having to see one of your providers?
Yes, they actually do. I actually see many patients from other clinics as long as I have that referral in the chart. And I have, again, I think kind of a good built-in relationship with a lot of providers here at Mercy. If I feel there's just a change that needs to be made, I will call the clinic, discuss it with the provider while the patient's here, and go ahead and initiate that change per that provider. Of course, documenting in my notes. But yes, we do see patients from several different clinics.
Another question from our audience. Are the patients scheduled for the linked appointment being seen for diabetes only? And then if other issues are identified, they schedule back the provider for another day?
So we have pretty bendable providers. They generally, if the patient comes in and they're just scheduled with me, I will discuss any issues with the provider, and we do tend to add them on that day. I think that over time, A couple of our providers initially were a little bit leery of that and would say, no, they need to come back. I don't have time to deal with that day. But actually realizing, I've really covered a big portion of that daily visit. I've got their vitals. I've got a rundown for them, so that they can come in, address that, and actually charge that office visit. So it does also help their RVUs as well. And all of them are very busy, but they do make time for me, and our patients, in a day.
Do you have tools, Karen, that you use to assess their knowledge?
So really, I think it is, we do have, again, that form. It is a specific form, and you can actually find that on the AADE website. They do have examples of those kind of rating tools. But again, it's sort of your perception of where that patient's at on their knowledge scale. So, just talking with a patient, you can really yourself, assess where they are at on that specific topic.
And how about food journals? Do you give them a food journal to fill out at home, or are they bringing in their own handwritten notes on their own templates?
Sure. It just depends on the patient. I have patients that are they're great historians. They have their own journals, or they have, again, they keep in, Fitbit or on their phone, and they'll print out these beautiful sheets. And then, of course, I have my own template built up that works for me. I have a blood sugar, insulin food diary printout that I've just created in Excel, and it works really well for patients. So I think whatever works, whatever the patient's comfortable with. And also, any of these CGM devices, they will provide you with specific journals for the patient, pair pads to send with them to keep that record on.
Another question from the audience. So are these patients scheduled into the provider's schedule as part of their regular patient load for the day, or are they on top of their regular day?
We generally try. We really try to have that linked appointment so that the provider's not overloaded. So we do try to actually have them on the provider schedule. So if a patient's scheduled with me at 10 o'clock, generally they're on the provider schedule at 10:40. Of course, that gets a little tricky when you're trying to schedule multiple appointments. But again, yes, there are days where if I see there's an infection in the foot that needs to be addressed that day, the providers generally will add them on that day.
Right. Karen, if our audience has any more questions now that our hour is up, is there a way that they can contact you, and can we send that out to them?
Absolutely, sure. My email address would be fine.
Okay. We will post that on Healthcare Communities, and we can also add it to the end of the PowerPoint.
Great.
Well. All right. Thank you, everybody, for your time, and have a good rest of the day.
Thank you.